Welcome back to the course in Nuclear Medicine Physics. Today, we're looking at the foundations of tomography. Now, tomography is a fancy sounding word, but it essentially consists of two Greek roots, meaning tomos, or slices, and graphy, meaning to write, in this case referring to the process of forming an image from the slices that you collect. We'll then look at the history of computed tomography, or essentially a sequence of X-ray scans that you take around a patient, and single photon emission computed tomography, or Spec. This will eventually lead into the mathematical techniques that we'll examine in future lectures about given data that we obtain in these different medical imaging modalities. How do we reconstruct it into a true image? So be sure to keep watching if you're interested.
All right, so today we will be talking about principles of emission computed tomography. So this comes from a composition of two terms, tomos and graph or grapho. And so, implying slicing or sectioning and also writing or recording. So the idea here is that in tomography, you are recording and creating slices into the image. So you're actually slicing your patient, but computationally, obviously not physically. So instead of projecting the entire patient onto a plane, you're actually finding a way to slice the patient in depth. So you're resolving depth, and you're not just getting a 2D image that has everything projected onto a screen. So that's the question of how do we actually do that? But the point is that by producing sliced images, tomography has the effect of eliminating blurring, which has been caused by overlaying tissues in conventional planar imaging. So you're moving from 2D projectional imaging, that you're only looking at a 2D image, that everything has been projected onto the screen, onto 3D imaging. And this can significantly improve your contrast and localization. For example, you're doing cancer imaging, you will know with better capabilities and better accuracy where the tumors are located, for example, anatomically. And there are many, of course, the tumors in emission computed tomography, you're imaging by its function, but you can localize better where in the anatomic context it is located, for example. And there are many different types of tomography. You'd be surprised at how many different kinds of tomography are out there, actually. And it depends on the nature of the wave or the particle that is being used, right? So there's many different waveforms and particles that can be used for tomography as they penetrate, for example, tissue, and also their origin. Are these coming from inside or from outside the body? And in a previous talk, we sort of alluded to this, right? So when you're doing scintigraphy or planar or gamma imaging or gamma scan, for example, in nuclear medicine, what you're doing is you're just doing a planar imaging of the source coming from inside of the body. The patient has been injected with a radiopharmaceutical, and the source, which in this case are gamma rays, are coming from inside the body. So this is emission imaging, right? And scintigraphy is analogous, as we mentioned last time in a prior lecture, to planar or projectional X-ray radiography. But the difference, of course, being that in X-ray radiography, the source is outside. So it's a transmission versus emission kind of a framework. So these define different kinds of tomography. And again, we talked about the fact that if you collect emission projections around the subject, you arrive at emission computed tomography, which is the topic of today's discussion. And so this in the field of nuclear medicine results in single photon emission computed tomography when you're doing single photon imaging, or positron emission tomography, which we will learn about in detail, where the positron ends up producing two gamma rays moving in opposite directions. But anyhow, in both of them, you're ultimately imaging gamma rays. And again, you're rotating the detector heads, for example, in SPECT imaging around the subject in typical SPECT imaging. Whereas in transmission tomography, the source is, let's say, the X-ray source, for example, if you're doing X-ray as your waveform, is outside the body. And so you're, for example, having an X-ray tube rotating around the subject with detectors, and that's going to give you CT imaging, again, if the source is X-rays. But the source doesn't have to be X-rays. It could be, for example, if you're doing in the optical domain, if your wave is not X-rays, but let's say optical or infrared and things like of the sort, then you could be doing like diffuse optical tomography when the source is outside the body, or if it's inside, it's like fluorescence molecular tomography and things like that, which we're not talking about at all. But just to really emphasize, there's many different kinds of tomography, and broadly you have transmission tomography and you have emission tomography. So it's very interesting to know, often it is thought that CT came before tomographic nuclear medicine imaging, like SPECT imaging. That's actually not true, and this is a very interesting historical note. In 1963, there was this really fantastic effort that was reported by Cole and Edwards, where they basically did tomographic imaging of radioactivity. And so they had the source, obviously, or the source is the radioactivity, but the detectors are rotating around the subject. Now, they did very simple image reconstruction. They did actually just back projection, which is the most sort of straightforward thing you can do. And we're going to talk about that today. But this was tomographic imaging. And so they were brilliant. They thought about this idea. And then only later, the CT scanner and tomographic X-ray imaging was really took off. And after CT imaging really took off, then nuclear medicine started to take off too. So the very first effort was actually in nuclear medicine imaging, but in practical, common usage, it sort of followed after CT. So CT itself, there were, the first commercially viable CT system was invented by Godfrey Hounsfield, Sir Hounsfield, and at EMI. And he had the idea in 1967, and it was publicly announced in 1972. There have been reports of other ideas or somewhat related tomographic X-ray imaging ideas before him, but he ended up really bringing it all together and creating, an operational CT scanners. And and it's interesting to know that EMI, by the way, is where, for example, they were doing many other things. The famous Beatles actually were doing their recordings in the EMI recording studios, and they sort of conceived the idea that maybe the worldwide we're going to need about 25 of these machines, which is an interesting footnote to history. And of course, CT is bread and butter of radiology these days. It's a fantastic modality. And so he had the idea that one could determine what was inside a box by taking X-ray readings at all angles around the object. And he said to work to construct a computer that could take X-rays at various angles to create the slices, so reconstruction. And so he essentially proposed the idea of computed tomography, or at least he was thinking he's the first one doing it. Turns out others had proposed the idea too, but he really went all in, and he built this scanner. And so he was not actually aware of, for example, work by Alan Cormack that had done on the mathematics of such a device. And in fact, both seem to have been unaware of work done decades ago by Johann Radon. And today we refer to this as the radon. Often we call this, when you do a projection, we call this the radon transform. So independent works, brilliant minds discovering this key idea that if you acquire data, projection data around at different angles around an object or subject, you could actually create 3D images of what's going inside. You could penetrate essentially inside the subject and do that. And the two of them, Hounsfield and Cormack, ended up getting the Nobel Prize in physiology or medicine in 1979. So the prototype CT scanner was built for the head, and Hounsfield tested it first on a preserved human brain, and then on a fresh cow brain from a butcher shop, and later on himself. So you can sort of see the kind of historic efforts that are going on here. And these are the kind of images that were initially obtained, right? So if you guys end up getting something like this in some of your studies, this could be a Nobel Prize for you. Don't give up. You know, this could change everything. And the scan time is interesting for this kind of an imaging was 9 days. Reconstruction took over a couple of hours, and they were printing images, and these are the kind of resolutions that initially they were dealing with. And so the first production X-ray CT machine was limited to making tomographic signal of the brain, and the acquired images in 4 minutes. So obviously this is better than his initial efforts. And the computation was about 7 minutes per picture. And this was actually a water-filled tank that it was like a head cap, and the head would go in there. And the reason this was used was to reduce the dynamic range, because if you're scanning just outside the head versus scanning, or just at the edge of the head, or going, deep through the head, there's a very different amounts of attenuation that's happening. So you're going to get a wide dynamic range of counts. And, back then they were trying to not have such a wide dynamic range because the detectors couldn't handle it. Of course, now they don't need to do that. Detectors are far better in dealing with different count rates. Yeah, so here's what you're having, history in the making. And so the first EMI scanner was installed in Wimbledon, England, and the first patient scan was made with it in 1972. And here's a scan that you're seeing here. And to honor him, the so-called Hounsfield unit is named after Hounsfield. And these are numbers that are very important numbers, reference numbers. For example, -1,000 Hounsfield unit represents air. So those are numbers that when in the scale of things, in the Hounsfield units that are used in the context of CT imaging, these are the kind of numbers that typically you have, especially the -1,000 and the 0, and then you move on to bone, etc. So in nuclear medicine tomography, we mentioned there's two modalities, there's SPECT and there's PET. So let's focus for now on SPECT, and then in the future, we will really elaborate on PET. In the 70s and 80s, and remember the very first tomographic modality in nuclear medicine preceded CT imaging, and it was SPECT. So in the 70s and 80s, gamma cameras then started to take off. They were developed, which could rotate around the patient and collect multiple planar images. Believe it or not, I know of people who have tried it another way. Instead of rotating, because they didn't have the mechanical utilities. Let's say you have just a planar, a really old device, planar imaging, and the subject is sitting here. And they didn't have the mechanics to rotate around the subject, right? However it is that you rotate, you could rotate like this, or if the subject is sitting, you could rotate around. They didn't have that mechanics in really old scanners. So there were people actually that would sit the patient on the chair, and they would rotate the chair, right? That's the same thing. If the detector is fixed here and you're rotating the chair, that is tomographic imaging. That's effectively the same thing. So that's an interesting, again, footnote of creativity. People said, well, wait a minute, we have planar imaging. Why can't we turn it into tomographic imaging by this quick fix? But of course, subject could move when they're sitting like this. So it's far better if the subject is lying down and then the camera is rotating around the subject. And this is what the gamma cameras were developed to do in the context of CT. And then the idea was to do tomography, as we've been mentioning. So most commercial SPECT systems are based on the gamma camera. We will be talking about exceptions. We already provided an example of multi-pinhole scanners. And multi-pinhole scanners, so we're having this comment here, it's a good one. Multi-pinhole scanners themselves there are ones that are actually stationary. They don't have to rotate because the way they're set up, they're already covering the patient in many different angles. So the beauty of some of these multi-pinhole systems is that they don't even have to move around the subject. We'll talk about that later. So this is a sort of exciting area. But typically you have a 1, 2, or 3 heads that are rotating around the subject. And why do we have more than one? Well, if you have more than one, you're collecting more counts, double or triple as many counts. So you're increasing the sensitivity and or the speed of acquisition, right? So you could rotate faster and collect the same number of counts. So you could do the scan at a shorter time with the same sensitivity. Or if you scan at the same duration of time, you're collecting more counts, so you're increasing the sensitivity. So it's sensitivity and or speed of acquisition. And 2D planar images, 2D planar images record the projection data, and then again, the camera is rotated to obtain the full data set. And image reconstruction is available by different kinds of modalities, and that's going to be a whole talk that we'll give next on how to generate these images. But just to contextualize this for you guys, before we gave you an example in a prior lecture about bone scintigraphy bone scan in the projection sense, but let's just now get again a feel. This is just an example. You know, what happens, for example, in bone SPECT, right? So moving away from just pure projectional bone scan to 3D visualization of the bone. So let's see what this happens, what happens here. So I'm going to show you guys a couple of videos. The first video is about 4 minutes, just to give you a context, a clinical context of what's going on.
Hi, my name is Justin. I'm going to go over a SPEC bone scan. On top of a regular bone scan, you would do a SPEC because you're looking for something in areas that have overlap of different bones, and it makes it a little bit easier to localize where a lesion and or a fracture or something like that is. What SPEC means is single photon emission computed tomography. Basically what we're going to be doing is basically a bone scan, but we're going to be taking it at different angles. The computer will later rebuild it, and that way the doctor or the radiologist go ahead and look through different slices and try to get a better idea of where the hotspot is or where the lesion is on the bones. Now, like I said before, on top of regular bone scans, some of the reasons you might do this is if they have a patient that has some lesions that show up on their spine. Spine has a lot of bony processes, and sometimes it's a little difficult to tell exactly where on the spine that lesion is. So SPEC can help the doctor with localization of that. Same thing with the pelvis also. Pelvis, when it's viewed in a planar view, a lot of times the different parts of the pelvis will overlap each other, and it's a little bit difficult to see exactly where the lesion and or the hotspot is. So SPEC helps to eliminate a lot of it. As far as the patient history and indications, basically the same thing as a bone scan. Definitely want to do them if you have a patient with prostate cancer, breast cancer, they have the lesion showing up again, like I said, on their spine and pelvis. Those are the two areas that it's mainly used for. In later parts of this video, I'll show you the positioning and how to set up the camera for that. So for a SPEC bone scan, what you're going to want to do is bring the patient into we're going to do the area of interest. In this case, we're imaging the lower spine and pelvic region. You'll take them in just so everything's in your field of view. It'll show up nice and bright on your bone scan because the radio tracer that we've given them has already had time to attach itself to the bone. And I'm going to show you in another angle. Basically, what you're going to want to do is bring the camera heads in close enough so you get far enough to where you get good pictures, but also you want to make sure that they clear all the way around the patient. Now, to do that, you bring them in and you slowly move them around, making sure it clears all the way around. Now, for positioning of a SPEC bone scan, what you're going to want to do is make sure the patient's in the middle of the field of view. The bed's up high enough to where it's going to be in the center of the cameras, because that camera is going to turn 360 degrees around it, and you want to make sure that picture's in the center of the camera the whole time. To do that, basically, you're going to bring put the bed in the middle of the field of view. You want to bring the heads in close enough to where they clear around the table, but are also close enough to the patient as possible. Best way to do that is to go ahead and spin the camera to the sides to make sure you have clearance on the sides of the patient table.
So dual head camera, obviously, dual head scanner.
So it looks like our clearance is pretty good there. We can probably actually bring them in just a little bit. Okay. Go ahead and keep spinning it, make sure it clears everywhere all the way around them. Okay, looks good there. We're going to go back to our start position. Now, other cameras have what's called auto body contouring, which eliminates the need to make sure you clear all the way around. The camera itself will have sensors that will actually sense where the body's position is, and it'll move the cameras in and out to get it to the closest possible position, but also not bump into the patient or the table.
So definitely there's movement in that direction where there's auto body contouring. So this is done far more automatically. And there's also safety aspects to this. If by mistake, this gets too close to the patient, obviously you don't want to be crushing the patient. And if that happens, suddenly these activate and the scan stops, and this stops to hurt the patient. So there's clearly a lot of engineering and safety issues that are behind this.
So once we have it in this position, we'll go ahead and enter our protocol information. At that time, the camera's basically going to move a step at a time, kind of turn counterclockwise, and it's going to take pictures 360 degrees all the way around. At that point, the computer, once you're done, the computer will rebuild it into an image that the physician can go through and look at different slices and try to get a better idea of where the lesion or the area of uptake is that we're looking at.
And the rebuild he mentions, of course, the technical term for that is image reconstruction, which we will talk about more.
This is an example of a process spec image. As I'd stated before, when we showed how we position the camera will rotate around the patient, taking pictures at different angles. The reason for this is the computer will then rebuild it into an image that can be divided up into slices. And this is advantageous because it gives the physician a better idea of where the lesion's actually at.
So these are the multiple projections. These are not the reconstructions. These are the multiple projections at different angles. And again, the image reconstruction will bring all of these projections at different angles together in image recon and create 3D images. So that is going to be what I'm going to show you now. An example, like a clinical example where, you know, an image is being read.
The nuclear medicine bone scan, whole body bone scan, or CT Spec, is a wonderful study. It can show areas of degeneration, trauma, infection, inflammation, or tumor. Here's one where multifocal degeneration was at play. You can hone in on the specific areas of pathology to characterize them better, to fit in with the clinical history. The study is a very useful one that I use often in conjunction with MRI scans.
Just to comment here, this is SPECT and CT. There's a lot of movement in combining SPECT with CT. And for example, we have now PET CT scanners, we have SPEC CT scanners. We're going to talk about multimodality also in the future. So the grayscale that you see, these are the CT images. And so often these are both in the same scanner. So it's a combined SPEC CT or combined PET CT scanner. So you're getting the CT for the anatomical imaging, and you're doing the SPECT or the PET for the functional images. So it's anatofunctional imaging. They're fused together. So again, by looking at these two kinds of images, fully registered and naturally registered because they're on the same scanner, the clinician is able to diagnose and assess disease much better.
I find that it has frequently guided clinical decision-making and treatment paradigms to optimize our understanding and outcome in such patients.
Okay, so that was to give you guys some context there. There's just one example. There's obviously many different applications. For example, cardiac SPECT is probably the most popular modality or framework of imaging in SPECT imaging. So there's many things, and as we keep saying, sky's the limit. You have many different isotopes that can be used, and you have many different radiopharmaceuticals that can target different molecular mechanisms. So what we have here is an example of a planar projection image. This would be obtained if you had a diverging lens. I've talked about this before. If you had a diverging lens, you could image the entire body using a single gamma camera. But in typical practice, you're using parallel hole collimators, and you would be then acquiring such a thing in multiple bed positions, let's say in 2 beds or in 3 beds, etc. So this is a projection just at one angle, right? And if you just look at the counts obtained on the detector along, for example, this line, you may get something like this, and we refer to that as a profile. So we got a projection image, a planar or a projection image, and this is a profile through it. So then the question is, how do we utilize the measured projection data that are obtained at various angles to generate images, 3D images? And the answer is tomographic image reconstruction. And that is exactly what we will talk about next.